Good evening. My name is Joseph Tucker Evans, and I want to welcome you this evening to Racism as a Public Health Crisis. I want to thank you for joining us tonight for an event sponsored by the Indianapolis Recorder and the Greater Indianapolis branch of the NAACP. Tonight, we have come together for a difficult discussion about the relationship between racism, health, and our hospital systems. From the heartbreaking stories of people like Serena Williams and the statistics around maternal fetal demise and maternal mortality, to the research that shows that African Americans across income and education demographics feel less safe than their counterparts, we have the responsibility and a deep commitment to have this conversation. There have been stories about the failures of our hospital systems to see African Americans as human, acknowledge their voices, and to treat them with care. We are not here tonight to litigate whether hospitals have defaulted on their responsibility. We are not discussing if racism or white supremacy are public health crises, or if the Black community has the right to demand change and expect something different from leaders of medical organizations. We know the answers to these questions. Hospitals and providers have defaulted in many ways. Racism is a public health crisis. Both all three of the CEOs who are on the screen tonight have elicited and published a statement saying as much. And the Black community is enraged that at their most vulnerable moments of their lives, that they are not safe and that they cannot get the care and the treatment that they deserve. So what we are going to do tonight is that we're going to ask you, what and how are we going to move forward? How can we hold each other accountable? And what should the Black community and the broader community do if these issues and problems are not resolved? Since 1912, the Greater Indianapolis branch of the NAACP and the Indianapolis Recorder since 1895 have been the voices of and advocates for the Black community. And so our job is not to debate with our special guest this evening, but to have an engaged and hopefully consequential conversation about what we're going to do and how we're going to do it with the people who have the power and the responsibility to make this kind of change. So I want to just introduce for a moment the folks that we have joining us tonight. We have invited the CEOs of IU Health, of Community Health, and Eskenazi Health to respond to the pledges that they have made and to a number of questions that we have designed and developed in response and conversation with one another. We know that these three CEOs all hire and oversee really more than 70% of the state's physicians, and that they run huge multi-billion-dollar organizations. And so while we don't have the time tonight to go through some of the stories and some of the legal happenings that have happened over the last year, we are asking the question, and a much broader question of, can Black Hoosiers and Hoosiers of color trust these hospital systems with their bodies? Can these institutions and the practitioners that serve these institutions be trusted with Black bodies, their care, and their ultimate well-being? So tonight, I want to welcome to this conversation the CEO and president of IU Health, Mr. Dennis Murphy. He joined the health system in 2013 as chief operating officer, overseeing the operation of IU Health entities throughout the system. And he came here from the Northwestern Memorial Healthcare System in Chicago, and he has now served as the president since 2013. I also want to welcome Miss Lisa Harris, Dr. Lisa Harris, excuse me, who is the CEO of Eskenazi Health, and for some 30 years has been working to support the vision of community wellness, and as a practice as a doctor and a caregiver, and has been serving as the CEO and medical director of Wishart Eskenazi Health since 2004, I believe. And then finally, I want to introduce Mr. Brian Mills, who is the president and chief executive officer of Community Health Network. He was appointed to this position May 1st, 2009, and he previously served as the CEO of Visionary Enterprises, a for-profit affiliate within Community from 1992 to 2009. In addition to these esteemed guests that we have with us tonight, we will also be joined by the president of the City County Council, Vop Asali, who will join us a little bit later during the conversation. And my co-moderator, Marshawn Woolley, will introduce our academic expert, Dr. Elizabeth Nelson, in one moment. I want to just take this time to thank you all for joining us and to give the regards of the president of the Greater Indianapolis branch of the NAACP, Crystal Ratcliffe, for helping to organize this event and for bringing us together for such a timely discussion. Marshawn.
Thank you, Dr. Tucker Edmonds. Good evening, everyone. I'm Marshawn Wally of I'm Just Saying with the Indianapolis Recorder. I'd like to welcome everyone on behalf of the community's paper of record and one of the longest running Black newspapers in the country. For over 125 years, the Indianapolis Recorder has been preparing a conscious community, and this program is just its latest effort in that tradition. Whatever happens to us without us is done to us. That is the common principle that we adhere to within our community. And so we think that it is poignant at this moment to have an opportunity to speak with the CEOs who have stepped forward and said that racism is a public health crisis and made some commitments to that end. And so we would like to educate the community to what this health pledge is and understand what's been going on. This pledge was made in October, so they probably need a little bit more time to get more results, but we still are very much interested in this program, and we are interested in the responses to the questions that we will be asking. But before we get too far into the questions, we really appreciate the opportunity to have someone of Dr. Nelson's caliber here with us. Dr. Nelson is an assistant professor in the medical humanities and health studies at IUPUI. She is a recognized expert in history of race and medicine, and she'll start us off by providing some historical context for tonight's discussion. Dr. Nelson.
In 2020, in the wake of widespread protest against police brutality and systemic racism, and having witnessed the disproportionate impact of COVID-19 on Black and Brown communities, health systems across the nation declared racism a public health crisis. Racism is a public health crisis. But to that, I want to add that healthcare has been a key battleground in the struggle for racial justice. In 1966, Martin Luther King Jr. said, "Of all the forms of inequality, injustice in health is the most shocking and the most inhuman because it often results in physical death." Civil rights organizations like the NAACP have long championed progressive health reforms. As you can see here in this 1949 article from the Indianapolis Recorder, Black leaders have been talking about the need for things like universal health coverage for decades, because health equity is essential for racial equity. Here in Indianapolis, hospitals have, of course, been central to the provision of medical care and health services, and therefore they've been central to the story of racial justice in our city. Oops. From the 19th century until around World War II, Black people were only admitted to one of the major Indianapolis hospitals, the City Hospital, which is now Eskenazi. And there they were confined to a substandard segregated ward. The other area hospitals excluded Black patients, even those experiencing life-threatening emergencies. In response, Black leaders, including healthcare professionals, business owners, women's clubs, and church groups, pooled resources and expertise to create Black hospitals. Two of the most important in Indianapolis were Lincoln Hospital and Dr. Ward's Sanitarium. As the historian and physician Vanessa Dorthington Gamble has written, the creation of Black hospitals demonstrates the strength and resilience of the Black community. African Americans were not passive victims in the face of oppression. Rather, they developed mechanisms to take care of themselves, end quote. So not only did these hospitals provide needed care to Black patients, they also created opportunities for education and employment. And in this way, they uplifted the community as a whole. So the desegregation of all the major hospitals in Indianapolis didn't occur until the 1950s. So a time that some of our elders, lived through, right? And I want to focus for a moment on this story of desegregation, because in some ways that moment parallels the conversation that we're about to have tonight. In 1952, there's a Human Rights Commission, which was led by a community leader named Louise Baptiste, issued a challenge to Indianapolis hospitals. The challenge was to end racial discrimination or be ineligible for funding. So in response, the leaders of 4 local hospitals, including Methodist, which is now part of IU Health, and Community East, which was then brand new, they agreed to a pledge. The pledge was to establish, maintain, and operate hospitals for the care and treatment of the sick, injured, or disabled persons without regard to creed, color, or nationality. So it was through resolutions like these that our local hospitals desegregated. So that's a hugely important moment for racial justice. At the same time, although hospital integration was a vital step forward, grave inequalities have remained. Inequities that have run through the late 20th century and into our own time. Black patients have not been given the same level of treatment as white patients. Black professionals have remained underrepresented on the medical staff and in hospital leadership. Health disparities have remained and in some cases even widened. Now, none of this is unique to Indianapolis. So just to go over quickly, a few national statistics. These are from the CDC. So today, infant mortality among Black Americans is twice the rate of white Americans. So that means that our Black infants are twice as likely to die before their first birthday than a white infant. Black maternal mortality is also an ongoing crisis, with Black mothers in the US dying from health problems related to pregnancy at 3 to 4 times the rate of white mothers. In terms of the pandemic, African Americans are nearly 4 times more likely to be hospitalized with COVID compared to whites, and nearly 3 times as likely to die from it. And part of this has to do with the comorbidities, conditions like hypertension, asthma, and diabetes that are more prevalent among Black Americans. One recent statistic that I found especially disturbing is the findings of a 2020 study, which you can read a summary of online in The Guardian. So this was a study that was done in Florida. The investigators looked at 1.8 million birth records over 23 years and found that Black babies cared for by white doctors were 3 times more likely to die in the hospital compared to white newborns. So further complicating the picture of health disparities in our nation is the fact also make us sicker before we even arrive at the hospital door. So this is due to structural racism. Because of racist practices and policies, Black people generally have less access to good housing, living wages, healthy food, and so on. We're more likely to be frontline workers who are more at risk of exposure to COVID. We're more likely to be over-policed and incarcerated, et cetera. So these are systemic disadvantages that chip away at our health and make it more likely that we will die prematurely. So these are complex issues and have been going on for a long time. And you'll also note that all the institutions represented on this call tonight are local hospitals, the Indianapolis NAACP, the Indianapolis Recorder. These are institutions and organizations with deep roots in our city. So tonight's discussion is just one piece of a much longer conversation and set of relationships. So I'll end here. So given that pledges and initiatives to combat medical racism and health disparities are not new, what can we point to that's different now? One thing I can say, and that does give me hope, is that on the call tonight, we have hospital leadership who are willing to call out problem of racism by name. And next, we'll be looking at the pledge that each of these leaders has signed. And you'll see that the language of the pledge accounts for some of the complexity of these issues, thinking about how to end discriminatory treatment inside the hospitals, but also thinking about what hospitals can do to address the structural causes of poor health. So at this point, I'm going to turn it over to you all to get into the details of that pledge and talk about how these hospitals are moving right now. Thank you.
Thank you so much, Dr. Nelson, for that overview and that context. We really appreciate your expertise and the work that you do in this field for the city of Indianapolis and this greater region. We want to jump into our first question. We have a number of questions that we want to get through with our panelists tonight. And our first question is directly connected to the pledge that was on the screen. In October of 2020, the CEOs that have joined us tonight came together and developed the pledge that was on the screen. And at the top of that pledge, they said, racism is a public health crisis, right? And then they began to name the ways in which they, as organizations and as practitioners, would begin to address that. So I have just an opening question for you, and we'll start with Mr. Murphy, we'll move to Dr. Harris, and then we'll end with Mr. Mills. I wanted to ask you, how did the pledge come about? Why did you feel like it was necessary in October of 2020 to make a joint statement like you all did? And what Black people or grassroots organizations were involved in helping you develop this pledge and statement at that time? So if you can answer those questions in about 3 to 5 minutes, that would be fantastic. And we'll start with Mr. Murphy.
Sure, and I may take them in a little different order. So I think given the tragic events of the spring, I think like many organizations, we started a listening tour at IU Health. And so when you ask who provided input, I would say our primary input were over 150 Black leaders here at IU Health, and really began the discussions talking about what did they want to see our organization do in response to those events. And there were themes that came out of that set of discussions. And they focused in 3 broad areas. First was, how do we improve the internal culture within IU Health to be actively anti-racist within our organization? The second was really more institutional sets of issues around policies, practices, and procedures. And the third was really focusing on these broader societal issues related to racism and disparities in healthcare. So in that first set of work around our culture, we were really focusing on the idea of how we think about training, how you think about behaviors, how you think about addressing those on a regular basis to set expectations and hold people to those expectations about how to act. In the second category on those institutional activities, that's about who do we hire, where do we look to hire people from? I think what does a living wage look like, and how do we support that within our organization? So a whole series of intramural sets of issues. And then on those societal issues, it's really those things that drive differential healthcare outcomes outside our 4 walls. And really knowing that we can't do that by ourselves, that we need to partner with people. But I do think there's a substantial role we can play. We, in 2019, committed $100 million to community impact investments, specifically related to those healthcare disparities. So it predated the activities of the spring, but it clearly brought to focus the need to do that work and do it urgently. And so I think the pledge came about that Dr. Harris and Brian and I talk periodically, and we all realized we were working on similar work, and that we would be benefited by the idea of talking about our work and how we could collaborate, but also learn from each other. And then I think the public nature of that pledge is an accountability tool that I think all of us agreed that if we're serious about this, we can't just keep it inside our four walls, that we need to be accountable and we need to be publicly measured and discussing what we're doing and how we're doing it, because I think we all believed it would make us better as a result of doing that. And so that's really how the pledge came about for us, was trying to get better by working together, but also trying to get better by being publicly out there saying this is important to us and we want to be able to talk about it.
Dr. Harris.
Go ahead.
Trying to unmute. Thank you. Thank you. And I also want to thank both the Indianapolis NAACP and the recorder for the effort it took to pull this together this evening. And I want you to know I'm grateful for having been invited to participate. As Dennis said, public statements are all about accountability, which is exactly what you're holding us to this evening. We, of course, at Eskenazi Health, we cared very deeply about these issues, and we've been doing a lot of related work. So we wanted our community to know this, and we saw the statement as a way of making sure we were held accountable. As we know, there were similar efforts playing out across our community and more broadly across the country. I was, for example, grateful to be offered the opportunity to make a personal public pledge as part of CICF's Inclusive City 2020 event at the Madam Walker Legacy Center back in October. Devastated by just the most recent in a long string of horrific examples of racial injustice, any caring and compassionate individual wanted to do something, wanted to declare to anyone who would listen, I don't stand for this. This is not acceptable to me. And I think as leaders, leaders want to say the same thing for their organizations. We don't stand for this. This is not who we are. However, if we're fully honest, we have to acknowledge that though this is not who we want to be, it is to varying degrees who we are. To deny this is to deny 4 centuries of highly intentional and highly effective efforts across our society that serve to dictate, based on nothing more than the color of one's skin, if and where someone could receive health care, get an education, where one could live, what jobs were available, on and on. The opportunity that America stood for was available to some, but definitely and deliberately not to others. So signing on to this public statement was one way of responding to the individuals and organizations that were asking us in the wake of the George Floyd murder, what is Eskenazi Health going to do? That was understandable. 28% of the patients we care for overall and 40% of the patients to whom we provide primary care are Black. Nearly 30% of our workforce is Black. So it's, and Dr. Nelson talked about our legacy. So it's natural that individuals were turning to us in this moment, and signing on to the pledge was one way of getting out the word broadly about what we were doing. And what we were doing was looking inward. We know what centuries of racial and social injustice can do, because our mission and our role in our community puts us squarely in the middle of working to address these injustices. But we know better than to rely on that legacy and our mission. We know that despite our best intentions, we are again, to varying degrees, carriers of the biases, the deeply ingrained mistruths, the policies, the institutions required to perpetuate the very injustices we work to address, that we push back against every day. We know there is much to do, and we know that actions speak louder than words. I'm listening, and I'm hearing gut-wrenching stories from our staff, our physicians, our learners, who have candidly and with compassion shared with me their lived and witnessed experiences related to racism involving patients, their colleagues, and themselves. There's no better use of my time. I've met in small listening groups with over 100 individuals at this point, and these sessions have become something I truly look forward to. Each group's been a little bit different. Each takes on new themes, but some themes are becoming very disturbingly familiar. We're going to continue until we're not hearing anything new, and I don't think that's ever going to happen. I'm really grateful to the participants for their willingness to be forthright and to share things that, as hard as they were for me to hear, had to be so much harder to experience and then to relay to us in the group. But the individuals I've spoken with to a person have approached this work with remarkable empathy and compassion and grace. A resounding theme has been wanting to find relatable space where we can all come together. I've been sharing what I'm learning with over 300 of our leaders in a series of half-day virtual retreats, and some of this has landed hard. But I can tell you that the energy and the engagement for responding to what we're learning and addressing these issues is higher than anything I've experienced as we've taken on this on important work like this. The major themes have formed the basis for discussion among small groups comprised of those 300 or so leaders that we formed to help us identify specific actions that we can take to address the four main themes that have emerged. And these are fostering an anti-racist culture, finding relatable space through listening and open dialogue, ensuring equitable and representative hiring and promotion practices, and identifying and revising policies and procedures that promote racism and exclusion. And I'm looking forward to sharing a number of the specific things that we're doing in response to the questions that we're going to be addressing. But the main point I want to leave you with is that we are committed to acting on what we're learning, to being just as deliberate in examining our organizational goals, our policies, our process, our outcomes, experiences of care, where we direct our resources, which organizations we partner with and support, all through the lens of racial equity with transparency and with the singular goal of being as effective in systematically hardwiring racial equity as were the efforts that got us to this unacceptable place of inequity. Our energy for this work is high. We will not lose focus over time or be distracted by competing priorities. Given our role and our responsibility to our community, there is no higher priority, and we thank you for holding our feet to the fire.
Thank you, Dr. Harris. Brian.
Thank you. Again, Brian Mills here with Community Health Network, and I'm so pleased to be invited tonight by the NAACP and Indianapolis Recorder. And I hope this is the first of many, many ways in which we find to work together. Similar to Dennis and Lisa, what we did in October was an outcome of things that started last spring. And last spring, with the horrific events happening in our country and locally, I started with my own reflection. I started with, okay, unless if we know history, unless we're going to work together, unless we're going to find something that's different, unless we understand what's really going on, we're just going to repeat this. And to me, this was a wake-up call to say it cannot be repeated this time. So the few of the basic things that we did fundamentally, my leadership team and I, it's 6 other people and me, we committed to identify common reading. So we had a little book club. And so we read these books every week. And so we read 7 books in a period of about 8 or 10 weeks. And we had reflection at the start of every meeting we had to try to understand what was going on. And it was important that we all got to the same point at the same time. And I'll tell you this, one of the things that I realized about myself that I had never, ever thought was that I grew up and have white privilege. And I'm not proud to say that, but I say that understanding that it's true. And I understand that by being real and transparent with the people that I work with. At the same time, I also firmly believe, inherently know that racism is real, it does exist, it is systemic, and it's in our organization. And I have an obligation to address issues such as this in my organization. So that doesn't make it easy. That doesn't make it say, oh, we got that resolved. It really just says, this is real and it's in front of us. So we've done a lot of things similar to Dennis and Lisa as well. We had listening sessions. And part of people would say, well, why you spend all that time? And the issue is, I've been here for 30 plus years and it's right here, but I did not recognize it. I'm not proud of that. but it's something about where we are right now. So we actually had listening sessions. We actually said we had people come together. We were not involved in these things because we wanted people to have safe conversations. And so we had other people come and do it, and they had sessions, about 1,500 people. And from those 1,500 people, we identified a racial and social equity committee of our top leaders and made sure that that was properly represented, by the communities we serve. And then they put together a list of subcommittees that continue to work on our behalf. So when all of a sudden the idea was, are there things, and a lot of things happened before this just occurred about us putting a pledge together. We were all working on things simultaneously. And then because we've been friends and had relationships, and I have just reverence for both Dennis and Lisa over the years, the idea was, can we hold each other accountable? Because I'd like to say I'll hold myself accountable. I make that pledge, but we get distracted. And that's not right. But if we do these things in unison, we will come together. And that's what this is all about. Because the issue is we can't let this be repeated. And by the same token, I would sit here and say, with the Indianapolis Recorder and the NAACP, one of the things, and we can talk about this more throughout tonight, we have to reestablish trust. If we don't reestablish trust, real trust, with our Black and brown communities, this isn't going to change. Because we can change policies, we can say we're going to do this, but to me, I'm checking boxes. As an employer, I can go through, and we're going through to look at our policies and practices and all these things, and we can do that. I can't tell you that's going to change the outcome. I can tell you that if we can work closely with you all and the communities that trust you, and you work with us, I think we can actually do this. But it has to be at eye level, not in ivory towers, and it's got to be with us working with one another to reestablish trust within our communities, so that we can work together and make sure that when it's all said and done, we're going to increase the life expectancy of Black and brown citizens. And that's what I would hope would be my legacy, our legacy, as people look back to 50 years from today.
Thank you, Brian. Thank you for each of the CEOs for the comments. When the Indianapolis Recorder was looking for data on the disparities that was happening as it pertained to COVID-19, it was very hard to get that data. And it was disconcerting in part because it seemed like, and the interpretation was that that was not a focus. And so I wanted to just put that out there now. Since the time that we have received the race and ethnicity data, it's clear that COVID-19 has had a disproportionate impact on Black communities. We knew that that was coming. We're concerned about the high rates of hospitalizations and deaths, and also the quality of care people receive when they're admitted to our local hospitals. You've made the above mentioned pledge in October, and we'd like to know what you're doing to improve healthcare and health outcomes for Black people in the context of the pandemic. I guess what we'll do is go ahead and start with Brian, and we'll go with Lisa, and then Dennis.
Okay, thanks, Marshawn. I would tell you that part of the early thing was trying to make sure that our data was accurate, that we hadn't pulled COVID data. Go back a few months before that, we didn't even really know what COVID was. So I would just say that data was delayed in getting to you, but you could be looking at any other slice and dice of that data and we would have the same outcome, because we were trying to make sure that it was accurate. So we have this accurate data. The data we have is unfortunately in compliance with what you've stated. And as we say, okay, what have we done since? I'm not going to kid you, we haven't not done a whole lot, but we make sure now every time we get together to go through data with our quality of care committees, with our physicians, with our leadership team, everything we do has a racial component to it. That it's not just data, it's not just how many, but this is how many of what ethnicity. This is how many related to treatments, how many related to who came through an emergency room versus other ways, how many are And so we're trying to educate ourselves on this and trying to make sure that we have a better understanding as we go forward. So this isn't something we've got to think about. This is part of our systems. So that data is plentiful. It's available to everybody. We review it all the time. And so, and once we have data that we believe is credible, then we can start working to make sure it's better.
I would add that our collective response to the COVID pandemic is really speaks to the collaboration among health systems, because we were very early in direct communication, really every day, as we started to learn and respond in the face of the unfolding pandemic. I think it's also, and so that's the cooperation that you're seeing here. I think it's also direct testimony to what becomes possible when a community decides that every resident of that community deserves to receive care in modern and efficient facilities. So because of the hospital facility that we were able to build with the support of our community several years back, we've had a different story play out here in Marion County compared to what we have heard about and read about in other urban areas. You know, all of the hospitals in Marion County surged to accommodate the high numbers of critically ill patients. And because of the design of the Sidney and Lois Eskenazi Hospital, we were actually able to increase our ICU capacity from 48 to 96 beds. So that was a doubling of ICU capacity. We could have gone up to 216 if we had to, but that looked like, you know, the number that became the number that worked. And this was because of building for flexibility. And then the air exchange and all the private rooms really enhanced the safety for our patients and caregivers. So if there'd been pictures taken here, they would have been very different than what was described for public hospitals across the country, where the narrative was one of the beleaguered, understaffed, overcrowded, public hospitals. That was not the case here because of the commitment and the compassion of residents of Indianapolis. We were very interested in understanding the impact of the pandemic on the patients we serve. So we have carefully studied the experience of patients within our COVID registry. And that means those who presented to us for testing and also those who received care within our system. And we have detailed information that we've been able to compare to the overall Marion County data. What we've learned is that consistent with our responsibility, our role here in the community as the public hospital that is focused only on Marion County, that is our statutory mission and mandate. We did have higher percentages of Black and Hispanic patients receiving testing and higher rates by a wide margin, especially for Blacks, of the chronic conditions that we know lead to worse outcomes for those contracting coronavirus. So this, of course, then led to higher rates of Black patients requiring hospitalization, and once hospitalized, becoming sick enough to require ventilator support. And this is consistent with what we did see play out across the country. What we were pleased to see, though, but not necessarily surprised to see, was that our mortality rate for hospitalized Black patients was not higher than for white patients. So patients who were able to, get to the hospital had the same chance of survival, actually a little higher likelihood of survival than their white counterparts. But the main issue, of course, is still, as we talked about earlier, that because of the higher rates of chronic disease, as you noted, Black Indiana residents have had higher overall death rates. So that's the main issue, but at least we could be comfortable that those receiving care in the hospital were not more likely to die than their white counterparts. And we're working to publish this and get it in wider dissemination as a counter narrative. I'd say, in addition, we talked about health being driven by factors outside of what happens within the walls of the hospital or the health system. Recognizing the contribution of poor nutrition and food insecurity on the chronic conditions that lead to poor outcomes for patients affected by COVID. In partnership with Gleaners, Second Helpings and Meals on Wheels, we've really ramped up our food distribution efforts in response to the pandemic. And since the beginning of the pandemic back in March, have distributed over 200,000 meals, over 300 of which were home delivered to quarantined individuals, and fed about 32,500 some families over this time. So this gets to the things that I know we're looking at in terms of the contributors to health and that lie outside of traditional medical care.
I probably want to apologize first because I didn't say thank you at the beginning for the opportunity. And like Brian, I hope this is the start of several conversations, because we, like everyone else, needs help if we're going to achieve the goals that we laid out in our joint commitment. As it relates to the question around data and outcomes, I actually, in preparation for this, went back. Our first COVID patient in Indiana was seen in March 6th. And then I was sort of recalling my email chronology of we needed to get PPE. We needed to figure out how to staff, like Lisa, change beds into ICU beds. But actually seeing what was playing out nationally, particularly in New York, we started tracking our data based on race for COVID patients 40 days after that first patient was seen. So I think, Marshawn, one of the questions is really what's accessible data versus what are we working with within our four walls. That public health department has that broader view. We knew this was a problem not just based on race, but also age. Very quickly pivoted to understanding this was a much more acute issue in older patients. I think very much like Lisa, we started focusing on testing. So we were the largest testing platform in the city, and actually went out into neighborhoods. So actually went to support the city's, Marion County's public health department with testing that IU Health was providing, and did that gratis because we knew we needed to get populations tested. And then once in our hospitals, we had very similar outcomes to Eskenazi, that we were measuring and monitoring. Did similar people have similar outcomes when treated independent of race? And we actually saw across IU Health that the outcomes were similar. And at Methodist Hospital, actually, Black patients had better outcomes than our Caucasian patients. So different outcomes. I think where we're really driving data right now is around vaccination, because there is what I would consider a massive trust deficit with the healthcare industry as it relates to anything experimental. And that our goal is really to understand how to be transparent with the information so that people can make strong, informed decisions, but then track the data and understand what are those points of resistance. Is it access? Is it technology and the inability to schedule? Is it in our own organization, the first waves of people to be vaccinated, or healthcare workers? Are we providing shots on the weekends? Are we providing them at night? Because that workforce needs them as well. So I think this issue about data was exposed during COVID, but is one that we need, as Brian said, there should be no clinical data that we look at that doesn't have some segmentation by race, so we understand where we have problems and what do we need to do about it. And I think the activities that we've learned in COVID now have us looking at every single encounter that we have to say, okay, if there's a difference, what's driving these differences, and how do we understand how to change that so that it's truly equitable care?
Thank you so much for those responses to the data issue. I want to just do a quick follow-up, and this can just be anyone who wanted to respond. Both, Mr. Murphy, you were talking about a trust deficit. Dr. Harris, you kind of mentioned this idea that, like the accountability is so key to this. I wanted to ask, where can people get the new data? And Dr. Harris, you kind of gestured in that direction. So if someone is saying, you just said that African Americans in Indianapolis are doing as well as white folks when they're coming into Eskenazi or into Methodist, where can we get that data so that we can hold each other accountable and see it?
Thank you for that. We will be making that publicly available. We have been careful. I think both Brian and Dennis alluded to this. We want to make sure the data is correct, especially when we're coming up with things that fly in the face of a narrative out there. We want to make sure that we have looked at every factor. And so we are just about at that point, but we are working to make sure that that is available on, actually we have our broad COVID data on the website, but getting it by race, we wanted to make sure, and this is really very timely information because we really are just at that point. We started first with just looking for the first several months. Now we've looked at the whole experience to date, and that's obviously a much bigger sample. It gives us more confidence that what we're out there talking about is correct. And so that is our intent. And then talking about some other data that we'll be sharing as well.
Just one quick follow-up. We're looking at the Marion County Health Department's data right now, and it says African-American residents had 130 deaths per 100,000, while the white residents had 122 deaths per 100,000. And so while the information that you all are providing is useful and good and positive information, we recognize that there's we're looking at the health department data and seeing something different. And so helping us understand the discrepancy will also be helpful, recognizing there's other hospital systems in the city and that all goes into the data as well. But thank you for making that clarification for us.
And also to be clear, we're talking about the mortality for patients who are hospitalized. And we recognize higher numbers of individuals of color being hospitalized. So when you go back to the population level, in terms of who all was infected, you're going to have some in there who may, knowing what we do about issues with healthcare, probably never made it to the hospital. So those are some of the things that drive that difference.
No, definitely. Well, no, that's so helpful. And again, this is just one of the things that as we're getting questions coming in, and we know that people are watching through Zoom and through Facebook. And one of the things that, folks are asking is, how do we follow up? How do we make sure that the ideas or the comments that are being shared with us, we can go back and check on as responsible and accountable partners? So we'll definitely be in touch at the end of this conversation so that we can get those data points and those websites so that we can do that for the listening audience.
Joseph, if I could interrupt. Yes, I think your point's really good, and it gets back to, I think, what all of us are saying. We want to be accountability partners with you all as well.
Yeah.
So I think as you are engaging with the people that are on this call and others who have inherent trust in what you do, I think we need to come together and not only provide the data, but distill it to say, what does this mean? And what do you do with it? Yeah. And because there's, we went from no data to we have so dang much data, we don't know what to do with. And it's really easy to get it, across purposes on things. And I think it'd be really, really ideal if we could come up with a set of data points that you all can say, you understand, you believe, and this is what's happening.
No, and I think that is exactly one of the outcomes that we want. Like, that's what we're looking for from tonight's conversation. And I think that this next question kind of builds on that, because, I started off in my comments saying, these are big organizations that we're talking to tonight. And that's why, we were very eager to have the CEOs with us. And we want you all to talk to us, that COVID-19 is just one example of the disparate and disproportionate care that received by Black patients and Black communities, right? Given all of the ways that your hospitals and your leadership can respond to and address health disparities, where are your individual hospital systems directing funds to address these issues right now, right? So we want to kind of from the top level office, from the leadership perspective, where are you all directing these funds? And how has the above mentioned pledge, right? This pledge that racism is a public health crisis, how has that impacted how you all are doing your budgets? So if you could talk to us a little bit, and Dr. Ash, we'll just start with you and on this question, if you don't mind. If you can tell us a little bit about where you're directing your funds to address this issue about disparate care for Black communities, and how has the pledge impacted that distribution of resources?
No, I appreciate that. Starting from bottom to top in terms of the operating budget. I was happy to be thrown in with this, some of those numbers. But the resources we get, we don't make a margin. You know what our responsibility is to turn every resource that we have into providing care, and our budget increasingly, and as a result of really becoming more sensitive and concerned about these issues, does reflect our systematic and strategic focus both on improving health for communities of color and improving opportunities for employees of color. And we also see economic empowerment as a means of addressing health disparities. So there are things that we're doing now with the resources we have that we weren't doing before. And so, for example, we've invested nearly $2 million. That's real money for us in education, a career ladder, leadership opportunities to foster this culture of inclusion and create opportunities for employees of color, the things we talked about. Just to pick out a couple examples, we have a career ladder program for entry-level employees to help us identify and then help individuals who are interested in moving up within the organization and gaining a better, higher paying job. And so that's about a $500,000 investment. We sent about 70 of our leaders to the Undoing Racism, that four-day Undoing Racism series. And that was a significant, that was a couple $100,000. Then you roll up the cost of, we have some mandatory annual training related to implicit bias, and that is an investment, and a significant investment has been in these leadership development institutes. I talked about the virtual meetings that we have of leaders, including physicians, and we've devoted all of those. We have those once a quarter, and we've devoted all of those specifically to the topic of racism, and that's about another $500,000 investment. And then things related, obviously, specifically to diversity recruitment and our fellowship program that we've developed for leaders, for individuals of color who are interested in assuming more responsibility in the organization, really deliberately helping to promote them and have a deliberate succession planning pipeline. Then in terms of community relations, again, this is about a $1 million budget for 2020. And this has to do with our sponsorships, our paid media. And the overall operational budget is, just for the community relations, is about $270,000. But and then the sponsorship budget is about $126,000. We've committed, starting in 2021, that at least 70% of our sponsorship budget will go specifically to issues involving race and equity. And so any organization that is going to receive sponsorship funding from us going forward must demonstrate a commitment toward improving race and equity in their work. And we've got a lot of questions to see if it's real. Paid media, again, we don't have a huge advertising budget. It was about $630,000 this past year. It was higher than usual, and that was directly related to the COVID pandemic. But more than it was about $630,000 directed toward people of color, and that represents about 52% of our overall paid media expenditure. And again, this was a unique year because we spent a lot of time getting the word out in terms of paid advertising to people of color, helping people know it was safe to receive care. We were very concerned about individuals who were going without chronic care that they needed. That, and we saw a lot of, I mean, the whole burden of COVID is much more than those who died directly of COVID. It's those who didn't receive care for cardiac disease and all those things. So we were really concerned about that and directed a lot of resources to advertising in that regard. And now we're taking that same approach related to vaccine safety. So then, capital investment is also a big bucket for health systems, and we are investing $75 million over the next 3 years in primary care expansion. All of our primary care sites are in underserved zip codes, and overall, the patients we serve in our primary care facilities are 45% Black and 32% Latino. So we are expanding several of our health sites, our healthcare sites at Grassy Creek, West 38th Street, and Blackburn in the 27th of Martin Luther King area. And we are going to be building a new primary care site in the 46218 zip code. And I think everyone's familiar with the composition of the population. It's 73% African American. As we're doing this, we are committed, as we are with all of our projects, and to make sure that we invest as many of those resources in local minority owned businesses. And our floor for that, the goal is 15%. So again, that's how you reduce disparities, by just getting wealth into the right places, trying to level that playing field. Then we're just taking a step at one higher level when we look at overall supplier diversity. From 2015 to 2019, we have nearly doubled our percent of MBE spend. So that's just been a deliberate progression that we're just going to keep going. And we work very hard as we did with with this whole campus project to make it possible for minority businesses to be part of it. And we're very happy with how that played out. So I think just one last area is that we've been focused for our entire existence on, we have this recognition of how much of health and healthcare outcomes are determined by things that have nothing to do with the direct provision of healthcare. They're all about the opportunities, the food, the safe places to exercise, the clean air, water, all those things that are about individual opportunity and healthful environments. And so we've been doing that work all along, but we decided we really need to kick up the pace of that. And so instead of all of us doing it along with everything else we're doing, we are creating a deliberate department to address that work. And we've invested $500,000 in new personnel that will be focused only on addressing these social determinants of health. One individual is Dr. Kimberly McElroy-Jones, who just joined us as our Director of Community Outreach. And I should say also that the Eskenazi Health Foundation contributed another $500,000 to that. So that's real money for us, and it's going to allow us to be much more systematic and deliberate, and hopefully get farther faster in addressing we're doing so much, and then we look at these numbers that Dr. Nelson showed at the beginning, and it's not acceptable. We all are trying to figure out how much more can we do, and are disappointed, I think, about how hard it is sometimes to try to move some of those numbers.
Thank you so much. That was I love the specificity there and the detail. Let's move to Mr. Murphy and IU Health as you kind of think about your budget and percentages that are going to these type of efforts.
Sure. Thank you, Dr. Tucker Edmonds. I think going back to our construct of how we're approaching this, we really look at investments in all three of those segments. So starting on the culture side, the data discussion, we're actually increasing the size of our diversity and inclusion office so that we actually have more project management resources to be able to track the activities, be able to put those out there, adding a communications officer to that so that it's available publicly. I do believe sincerely transparency is the ultimate accountability tool, that you have to be brutally transparent and honest with your data and your performance. In that culture category, we also have training that we've increased substantially related to bias and civility training within our organization. And, it's been interesting taking this pledge during COVID, how you think about rolling out training, particularly training in this domain where I'm not sure Zoom is the right way to have a crucial conversation with someone. You really want people interacting. You want people role playing. You want people having those hard discussions. So I think we're committed in terms of the resources. We're now trying to figure out how you actually use them in the best possible way. In that sort of policy, procedure, and activity area, a big commitment we made a couple years ago was related to this idea of how do you get people good jobs? And good jobs were defined by the Brookings Institution for Indianapolis as $18 an hour with material benefits. And so we've been raising our lower end of our pay scale. And this idea that you'd get people to those good wage jobs with a mutual commitment that people would be at IU Health for a number of years, 3 to 5 years, and how would we get them to that $18 an hour, either in their jobs or in other jobs that we scale up their training for. So also training programs. That initiative alone, we actually think we're going to impact over 9,000 people in that program. Again, IU Health's a big place, so the numbers always get bigger. That's about a $20 million investment just in that program alone. Lisa talked about capital. We are committing over $1.6 billion, will be the single largest investment in downtown Indianapolis to rebuild University Hospital and Methodist Hospital. And we have similar XBE and diversity goals in terms of the people who work on that project, but also the vendors that we deal with. I think we want to make sure that we see programs that yield jobs out of this and programs that yield economic benefit to companies themselves and minority-owned companies. So I think we want to see the diversity metrics on both ends of that spectrum. The area that I think we're excited about is this community impact investment. So pre-COVID, we saw investments in congregational partnerships. So how do we get out to partners in our communities who have trusting relationships with people in the community to help talk about health issues and outcomes? We actually invested in a crisis diversion program. So these are people with addiction problems that enter the criminal justice system and are probably better served outside that system. There are really material issues with maternal and fetal disparities in terms of outcomes. And we started a Healthy Families program here in Marion County. And those investments are about $3 to $4 million a year. During COVID, we actually pivoted and saw investments in everything from support of early childhood learning, access to broadband, like Lisa, food insecurity was a really significant issue, and also daycare. So for the people who wanted to work, that they could work. So how do we support organizations that are providing those activities? So, I think there's going to be a almost bottomless set of needs. And I think for all of us, we're learning how to make wise choices. And the single most important thing we've learned is that you can't do this stuff by yourself. We've now got a requirement on all of these investments. They have to be driven and proposed by a partner, and we have to be in a supportive role in those activities if these are really going to be successful long term.
Brian.
Yes, Joseph. First of all, I'm always impressed by so many things that IU Health and Eskenazi do, and we follow in their track as well. I think part of the other reason, one of the other things by which we're accountability partners, is that we, the three of us, continue to make investments in Marion County, and we could choose to do other things. I mean, we rebuilt Community East a few years ago, and everybody thought we were going to leave the East Side, and we didn't, and frankly, never considered it. And we continue to invest in that campus, just like Dennis and Lisa are talking about, but also our North and South hospitals are in Marion County as well, and we continue to invest in those places. So there's, there are dollars there that we say look like structures or programs or things, but they're things that we are trying to continue to invest in what we need to provide care here in Indianapolis. The second thing is, goes back to when we started talking about this issue and what do we do about it, and I won't go through the journey again, but my comment was, look, we spared no expense to fight COVID. This is as big as COVID. And so we cannot spare expense to address racial and social equity. So I will just say arbitrarily, which it was, we said we need to form this committee that I've talked about, this RAISE committee, and I need to empower that committee, not meddle it, not question their actions. I realize that they may make 50 decisions and 25 may not work at all, okay? But they need the ability to try and fail. So arbitrarily, I just said, here's a committee, here's $10 million, go do good. Go do things and don't hesitate. And that wasn't a one-time deal. That was something to get us started. And so as we go into this year, following years, we're going to continue to do that. What do we need to invest? I don't know. I'm just saying this is something that we have got to finish. The other thing we've done, and again, high reverence for what Dennis and Lisa do, but in the whole idea of how do we train physicians? Okay, our residency programs are not the size of their residency programs, but we've trained a lot of primary care physicians over the years. We started training behavioral care physicians, psychiatrists years ago. We keep expanding our primary care. We're expanding. We've expanded psychiatry again, and we've also added addictions fellowships as well. So again, that's us trying to understand our community and making sure we're training people, because people get trained and it's really hard to make changes from there. So, and then obviously no different than the others, we're trying to relook at the investments we make into and making sure that we're dealing with people in Marion County with initiatives they have to help our citizens. We've long been big supporters of United Way of Central Indiana. That's something that we continue to do. That's something that we continue to have a large participation by our employees supporting as well. So we will continue to look for opportunities within these communities and all communities and saying, let's redirect our dollars. That's making sure that the dollars that we spend, we believe have a chance to help our citizens. That's never guaranteed, but it's not an investment wanting a return. It's an investment wanting better health for our citizens.
No, thank you so much. I know we're going to try to get to one more question as President Osley joins our conversation with us. I know Marshawn has one. I want you all, as Marshawn asks his question, to be able to answer maybe yes or no in a minute from me. Are you committing to do that? Like, how many more years are you doing that 10 million for, Mr. Mills? Right? I want, kind of having a sense of how long that commitment is. But I want to get to Marshawn's question before you answer that. But I want to, a lot of folks in the chat have been saying, 1 year is good, but is this a long-term commitment that these CEOs are outlining? Go ahead.
Yes, and actually you can integrate that into the question that I'm going to ask you. So we asked a budget question very intentionally, but we also appreciate that healthcare has evolved, and it actually speaks to the question that happened earlier on data. So this is the actual data question. As you're working to improve care for marginalized communities, and particularly communities of color, how do we know what you are doing is working? So we mentioned, the distinction between what you all are doing internally and the data that you have internally. But if I go to another website that's out here now, there's a whole different set of data that we're looking at, and we're trying to figure this out. So what's going to be important is, what are the metrics you're using to measure health outcomes for these communities? And I think that goes back to the question of trust. And are you able to assess whether or not these outcomes are improving over time? How can the communities access this information? And I think also in your response, if you could go ahead quick, how long are you doing some of the budget things?
Well, first of all, I believe I said when I made my statement a couple of minutes ago that the 10 million was not a one-time. It was continual. I did not know how much it needed to be, but there's no end to it, because that committee has got to continue to know that they're resourced for what they're trying to do. So that's one. Two, back to the data information, we now have data segregated, by ethnicity. So therefore, we can establish those outcomes, and we can say, here's the goals we're taking and here's the investments. But I got to be candid with you. I'll go back to my earlier statement. We have got to find a way to establish trust between us, because I'm not confident. I'm not a physician, but I sit in a lot of rooms with them. But I believe if we can't establish trust, the changes are going to be minimal. I don't think that we're going to achieve what we all want on this call unless we can work together to find a trusting environment that we can work with each other. Because the issue is outcomes are downstream. We got to go way upstream to make changes to impact that outcome. And that outcome may be something that we're getting because something didn't happen as it should when somebody was 2 years old. So that's I'm just saying it's got to be. I'm not trying to say outcomes are important. Please don't take it that way. I'm just saying making outcomes different requires engagement long before the hospitalizations, long before the surgery, long before whatever event it is. And so we've got to make sure that we're working with you to try to address that and establish that trust.
And I think, Marshawn, it's a really interesting question, because all of us have localized data. And I think what the community wants to know is what's our collective outcomes. And so it's probably one that we need both. So we need to be transparent on what's happening within our four walls, but then sit down collectively and look at what's going on in our community and have that shape our response as well. And so This is one of those difficult times where I think both Dr. Harris and you are correct that I think there are institutions where we're doing well within our four walls, but if the community overall is not doing well, then we are collectively failing. And so we've got to make sure that, I can say for our institution, you can't go to a website and see our outcomes data. But I'm committed to us seeing that and showing that on a regular basis. I've got to figure out what that looks like and how do we make sure that the general public can interpret what that means. And to the economic question, our building is committed. Even with COVID, we're not changing our project at all because we believe it's critically important. The community impact investment numbers that we talked about, we've actually segregated as an endowment and said that can never be touched. So that is 100 million in perpetuity towards that issue. And our board would like to see us grow that pool of money based on our success elsewhere. So I think that is our initial commitment. And over time, we will grow that. And again, the commitment to our employees, we're baking that in as part of what we're seeing moving forward, that we're never going backwards on our wages, that we believe that idea of a living wage is important for the vitality of all the people in the communities where they work with us.
I will provide just a few specifics because as representative of the things that Brian and Dennis were alluding to, just so you know that we are looking at these things and we have information again that might we might find encouraging, that we would hope would eventually roll up and result in those high-level population numbers, finally get us out of the one of the least healthy states, the least healthy county. You got to start somewhere, and we have we've been looking at all of our processes and outcomes of care, and the more we learn, the more questions that we ask. But just specifically looking at what we've talked about in terms of coronavirus, that we know about the chronic conditions that lead to more severe disease in minority communities. And so we looked specifically at diabetes control, found out again we're doing a little bit better in Black patients than for whites. Also with breast cancer and colon cancer screening, and we were happy to see that. However, we're not doing so well in blood pressure control. And so, and that's something we've taken on as a system goal, and we'll be working into our quality metrics for our physicians. This is another point of intersection. Our specialty physicians are physicians of IU health physicians, and it turns out that blood pressure control is actually a population goal for IU health. So that's a nice point of intersection, and hopefully more collective impact. But Dr. Crabb, who's our chief medical officer, has really been working with our physician leaders and just asking them to go and look within their areas of expertise and look for the things that they to be curious and to see what where we can do better. And we actually have a Black pulmonary physician, Dr. Francesca Duncan, who's doing incredible work in lung cancer screening and addressing. I think everybody knows that there are issues in looking at this, because sometimes so the guidelines, like guidelines for lung cancer screening or other approaches to care, don't always include Black patients. So they're not letting that be a barrier. They're figuring out how to develop a meaningful approach to creating equity in screening, and that will inform eventually. You get it published, then it informs care of individuals everywhere. So that's one example. They also just looking at adherence with HIV medication, rates of specialized treatment for atrial fibrillation. It's all over the map, and they've got a lot of energy. They report this to us in those leadership sessions that we talk about, and you can tell they're really excited about it. They're doing this work even as we're responding to the COVID pandemic. So the same physicians who are leading the teams in the critical care areas and you all know what that's like. We hear about burnout. We hear about, just what it takes to continue this kind of concentrated, intense effort for almost a year. They're still doing this work, and I'm really grateful for that. I'll just say. And then, the other thing is we know that patients' experiences of care can affect their care outcomes. And we actually have some data related to trust. And so, we have, on the one hand, we were actually studied as a public health system across the country where we, on one level, enjoy a high level of trust with our community. And this is something that's going to be published. We didn't know about it. Someone came to us and asked, said that they've been calling data that's publicly available and identified us as one of these institutions. Well, that's great, but that's high level data. We're looking a little more granularly, and we're finding. So we have a national firm that does our patient surveys, and this is how we compare ourselves to others. And so we've reached out to them and say we want to get all these data by race. We haven't historically been able to get that breakdown, but I'm sure that there are health systems all over the country who are saying, we want to know this. And so they are working on it. But meanwhile, we started collating it on our own. And we found that in the hospital setting and in the emergency department, we see similar reports of Black and white patients describing the degree to which they felt that the physicians and nurses were listening to them and treating them and their families with respect. We found similar reports of confidence in caregivers overall and likelihood to recommend us. But when we go to the outpatient clinics, first of all, it's harder to collate, and they're all individual. And again, we find many similarities, but where we find differences, it's generally in trust. So that's something that we can put a needle on the map and see if we can move it. And again, the trust is lower for Black patients. That has obvious implications as we're working to help people become comfortable with receiving the COVID vaccine. So I mean, back to the issue of sustaining our funding, I will say, given our role as a safety net health system and the large proportion of uninsured and underinsured care we provide and uncompensated care we provide, it's, we are always, really looking, having to be very careful about every resource, and often something we do, it means something else we can't do. So we're very deliberate, but this is the work that we are devoting those resources to. And we have had an effort over the last 3 years where we have reduced our dependency. So we get supplemental funding as that recognizes this high volume of uncompensated care we provide. Those sources are, they're not necessarily consistent. They're not guaranteed. And so, we're really working to shore up our resilience against any threat to those supplemental funding because of our commitment to this work that we're doing and our responsibility to our community. And so over the last 3 years, we've actually reduced or improved our financial position by over $130 million. And that work is fueled by the commitment to making sure that we don't waste any resources, that we have everything available to continue to commit to this. So our commitment is to, this is part of our budget. We're standing up the whole department. We're not, our intent is not to let all those people go next year.
Outstanding.
But that is what is, that commitment and really being concerned about the enormity of this work and being frustrated about how long it has been to get to this point is what gives us the energy to be very, very intentional, do the hard work of managing our resources as effectively as we possibly can.
Well,
Thank you, Dr. Harris. One thing I wanted to just observe really quickly, I think, and we've talked about trust, there's an opportunity to work with the community to help establish those metrics. I'm not going to ask you to do that. I'm just going to present that as an observation.
Excellent, Marshawn. We're right on the same way that I said, you know, what is the trust metric, right? We talked about a trust. What is this trust metric? But I want to introduce our guest who just joined us, President Vop Osili. He was appointed the president of the county council, city county council in 2018. He was first elected to the city county council in 2011. And so we want to bring him into the conversation. And my job was to ask someone to bring up the pledge from the city county council about racism as a public health crisis and President Osili's quote. And I wanted to just let you know, Mr. Osili, that we've been talking for this first hour really about the pledge that the CEOs of these major hospital systems came up with. We've talked a little bit about how do we share and engage data between each other, between the hospital's data information as well as what Marion County data has and how we make that accessible to the broadest group of people. And then we were just finishing up, as you joined us, looking at some of the budget issues. How does this show up and play out in the ways in which these hospital systems are constructing their budgets and their priorities, right? And so you heard that as you joined us. And so now we want to pivot to you. We're going to give you, about 5 or 7 minutes to kind of make an intro statement, because before the CEOs of the hospital made their statement, President Osili was making a statement in June. And he was drafting a resolution, I think it was resolution 182, right, in June of 2020, that was saying that that racism was a public health crisis in Indianapolis and Indiana, and that the city county council was going to develop a resolution that was going to respond to this. And so what we want to ask you, Mr. Osili, President Osili, is how did you come to wanting to kind of have this as your pledge? What led you to this moment? And why did you specifically focus on the Black community? And this quote that we pulled out here, I think from the Recorder, where you were talking about the pledge. I don't know if it's from the Recorder or from the Indy Star. So how did you come with this pledge? Why did you identify Black, African Americans or Black folks as the primary folks that you wanted to focus on? And how do you plan to resource this pledge or this commitment as we move forward? What's your plan for putting this pledge into action? And I encourage anyone who has not read it to take some time. We will make this document available to read the whole pledge and the whole resolution. But I want to hand this over right now and take no further time with President Osili.
All right. Thank you very much, Dr. Edmonds. Can you hear me all right?
Yes.
All right. Let me start off by saying thank you to the NAACP and to the Indianapolis Recorder for this panel this evening, and to yourself and to Mr. Wally. And I see some impressive panelists over here, Dr. Mills, Dr. Harris, Mr. Murphy. So glad to be on the panel with you. We started off with this, recognizing that for centuries, government has perpetuated the policies that have led to generations of disparate health and wealth and economic outcomes. That was a basic. And we realized that we also play a role in that we are local government. And if we continue the policies that we have, we will continue the outcomes that we see. And so working with my fellow colleagues, it just became a critical element last year when we decided that we were going to take this on. Not last year, 2019. We determined even back in February that was going to be the direction that we were going to go, that we were going to look at equity. And then how do we create policies and processes that create more opportunities for everyone, for Black and brown as well as white, but how do we get to a point of equity? And it doesn't happen overnight. And it doesn't happen by wishful thinking. What it does is it requires us to be intentional with our actions. So working with our colleagues, so this was not just me, this was my fellow counselors. deciding that we were going to put a stake in the ground and say, this is the approach that we are going to be taking. So in short, if you want to look at, for example, some examples of the impact, and tonight we're talking about racism as a public health crisis, let's just talk about it as a health crisis. And let's go back as far as redlining. And I think we all know what that is. Basically, surrounding and placing Black and brown people, primarily Black people, in the city of Indianapolis, in areas that were close to industrial sites, pollution-causing industries, exposing Black people and basically saying, you can't move out of these areas. We won't give you the money to do it. We will drive you out if you think about moving out of these areas. So exposing them to environmental toxins like lead, the poor air quality that these individuals, like my own grandparents and my own great-grandparents, I'm a fifth generation Indianapolis native through my mother. The things that they had to endure in these communities led to greater rates of things like asthma and respiratory diseases, those very same diseases, by the way, that were exacerbated by this COVID pandemic. And so even in these communities, challenges of access to nutritious food, which contributed then to other issues like higher rates of diabetes and hypertension and obesity. Once again, these very same kinds of diseases that were exacerbated and that we saw exacerbated in the COVID crisis. So what we committed ourselves to do was, first of all, to have the discussions, the frank and open discussions about race and the impact of the decisions that we and government, the decisions that we make on the racial inequities in our community. And then to work together on these. But if we don't talk about them, we don't get anything done. So I think I heard someone use the term accountability tool. What we determined is that every single department and every single agency in local government was going to present its budget and was going to make the determination on the impact of equity with that budget. So we created a baseline this last October when we finally voted on it. This is what we're going to, here's where we are today on issues like staffing and procurement and contracting. And then we were going to collect that data and we were going to disaggregate it by race so that we have a clear idea and have those, I think some people call them adult conversations. We were going to have those adult conversations so that we could see where we stood. And it becomes an accountability tool for us every single year as we go forward. Are we doing what we said that we were going to do? And that's make decisions so that we have more and more and more equitable outcomes. And if we don't do those things, and if we don't have those kinds of measures in place, then we can expect more of the same. We can expect these same kinds of disparities in health and in wealth and in economic opportunity. And so we play a role in that. And if we get it right, and the more and more that we do get it right, the more and more then that we can work with our community partners, our health partners, our business partners, to say we're doing it and we're going to expect you to do it too. That if we're going about this and we want to work together, here's a standard that we're all going to have to follow. So this is how it came about. We were basically saying, how are we going to direct our funds? I remember my own pastor saying once, you know how much you love your wife, but how much you're willing to spend on her. I don't know if that's true or not. I'm just telling you what he said. I'm just repeating what he said. At the end of the day, what counts is where do we put our money? And are we putting our resources into communities? And this is something that we have to do intentionally every single day. Are we putting it back into our communities so that we have opportunities for equity, for health, and for wealth? And this is how it evolved. And this is our pledge going forward every single year, department an agency being accountable to our constituents and to our community.
So if you're wondering why I had all that specific data, it's because of what he just said. They drove that accountability, and that's our budget presentation was very different this year compared to past. So I can attest, and that's why we're looking so specifically at the numbers.
Thank you, Dr. Harris.
Thank you for that.
Thank you, Dr. Harris. Thank you, President Ostley, for that overview. Just one quick follow-up, and then I want to hand over to Marshawn. When you're saying, every department, every area is going to kind of follow that initiative, what are we talking about in terms of dollar amounts, and we've been asking all of our partners today, how does the average Indiana or Indianapolis citizen find out how to hold you accountable for what you're talking about? Is there a website that we should be going to? Is there some?
Thank you for asking that.
Yeah. So,
yeah.
And then we'll go to Marshawn. Sorry about that.
So our commitment from every agency is to make this data publicly available through their websites. So Dr. Harris, I don't know, we haven't checked, but is that data available yet on your website? Not to call you out.
It's in process. It's in process.
All right. Well, that has been the commitment that we made back in June, and that is what we're following through with. So yes.
Great. So what I want to do now is transition to another area of accountability. There's actually been quite a bit of frustration within the community regarding representation, particularly at the leadership level within our hospital systems. And it's been very concerning, particularly at this moment where folks are trying to, deal with advocates and identify advocates when they go to the hospital. And we'll ask that question a little bit later. An immediate issue that was raised in your joint statement was racial representation within your organization. So specifically, Black people on boards, Black people on at the VP level, at the C-suite level, the director level within the organizations. What is the current racial representation within your organizations, especially key leadership positions? Because the observation has been, we find Black people in HR, we find Black people in supplier diversity, and rarely do we see folks outside of those positions. That is concerning. We're interested in Black board members as well as medical and support staff. And what are you going to do to improve what is in the community perceived as unequal representation of communities of color in your institutions? So what I'd actually like to do, we'll start with Dennis and then we'll work our way up.
I think, Marshawn, it starts with a simple premise of our organizations need to reflect the communities we serve. And so when you think about what's the goal, and when we look at our entire workforce, as you said, we actually look like our community and what we serve. But when you look at the distribution of where people are and what roles they play, it's not representative. When we look at our board, we are now on our health system board, 20% of our board is Black. So we have, as a result of the activities, gone out and recruited new board members to our board to improve that metric. It's a little easier, I would tell you, because when people retire or roll off your board, you're not firing someone to create a slot. You're not, there's a more natural progression for us. So that was actually an area we could address fairly quickly. And when we think about our management team and our leadership team, right now we're at about 12% of our leadership team are comprised of people of color, and 8% are Black. And so we do not reflect the communities we serve in that. So then I think it's really, what do you do to change that? And so We have hired a specific diversity recruiter for our leadership roles. We are working with historically Black colleges and universities to recruit different talent than we would normally recruit from. There are some national organizations and even local branches of those for Minority Nurse Association. There's in a health management side, there's a group called NACI that I've worked with in other capacities that we're working with to begin to build that pipeline of talent within your organization. So I think it goes back to what's your goal, and then what are those pipelines you're building in your leadership programs. We've actually said in all of our leadership training programs for IU Health, we are allocating a certain number of seats and percentage of seats to people of color. So it's a forced requirement to actually say you're going to pick candidates for those management training opportunities in the organization. On the professional side, it's interesting. Indiana University is actually the largest medical school in the country and does really well in its medical school class in recruiting diverse talent. They actually have a higher percentage of people of color in their medical school than most major universities in the country. What we see is we lose them. So when they go for their residency, their fellowship, or they go to take their first job, each of those steps, we see a reduction in the percentage of people who stay here. And so we're actually trying to work upstream with our medical students who are coming out with debt and a fairly substantial amount of debt to begin to capture and create programs that say, we'll partner with you, but we want you to stay in Indiana. And we want you to stay and be a part of IU Health. And so we actually have a faculty member who's part of the school's diversity team that's creating a program called iDream. And IU Health will be funding that program and really using that to drive retention, because I think that's our key issue is we train lots of great people. How do you create a place that they want to stay? And how do you make that a good decision for them personally when it comes to their finances? So really trying to create pipeline programs there as well.
Thank you. Dr. Harris?
Well, so we have a couple of boards to whom we are responsible. First is the Health and Hospital Corporation Board. As I think everyone's aware, Health and Hospital is the municipal entity that owns and operates Eskenazi Health. And that board is comprised of 40% Black individuals and 60% white. We also have a board that governs our federally qualified health center, which is distributed through that's all of our 12 primary care sites across the city. And there we have 50% Black representation, 30% Hispanic, 20% white. When we talk in terms of leadership, at our larger senior leadership team is comprised of 27% racial minorities, 20% of whom are Black. And if we get down to what is typically referred to as the C-suite, slightly smaller group, that's 20% Black. You asked about individuals in specific leadership roles, and we actually are the CEO of our aligned physician group, Eskenazi Medical Group, is Dr. Curtis Wright, who is African American, and Sharon Rogers is our recently appointed Chief Financial and Strategy Officer. And then we have others at the VP levels. So those numbers start to get close. Again, Dennis made the great point that the whole point of this is we want our leadership to mirror the our workforce and the patients we serve. And so we know overall our patient population is 28% African American. When we look at our workforce, though, about the same, about 30%, and that's different depending on the type of worker. So our licensed professionals are about 19% Black, but non-licensed 45% Black. So that makes it incumbent on us to have higher goals and higher or to work to make sure that people can look up and see people who look like them. And that is actually one of the comments that we get regularly from the employee listening groups is, we don't look up and see people who look like us, or there's no one to reach back and bring us along. And so we looked also at our director and manager role, and there we see we have a particularly good opportunity. We've got about 15% representation of Black individuals among our directors and 18% among our managers. So there is at that level of middle management, particularly, we have work to do, and we're really. I know we're coming down the end of our time, so I'm not going to go over all the specifics, since they're very similar. We've talked about the, our specific fellowship to train, to identify and train up and nurture individuals who are looking for greater responsibility within the organization, and the same efforts in terms of diversity recruitment, and also benefiting from the diversity within the school, because that's a major pipeline for us.
Marshawn, I'll be brief in my comments so we get through this. First of all, I think it's a very fair question. I think that we should represent the communities we serve, and I can tell you right now, we're not doing that. However, I mean, we've had conversation about things that we have to do to improve that. That would start with our governing board, which is our network board. And our network board for years has had a cap on how many board members we have. I'm pleased to say that within the last, it's probably 3 months now, 2.5, 3 months, they have agreed to add 3 additional seats that we've never had to address this purpose. And so that process is underway. And I think we probably needed a nudge, and I'm glad we're doing this. And so thanks for identifying that. If you go into my senior leadership team that I talked about briefly, we also need to make progress. We have 1 member of our 7-member senior leadership team that is a Black female. She is our general counsel. So, I mean, it is a very important role, and it has all kinds of other roles within our organization. But we've had conversation as well. We need to make sure, A, if we add other positions, we're doing that, and B, if we have turnover, we're doing that. But most importantly, we have to be an example for the rest of our organization. And if we're not that example, we can't ask other people to do things that we're not doing. So I think your questions are very fair question, and we need to have a better report.
We appreciate the transparency. Thank you.
Yeah, thank you so much. And again, we'll be looking forward to data and updates on what you all just shared. I want to go to a really pivotal question, I think, for this evening. I think a number of folks in the chat have posted and asked about this, and we've shared these questions with some of these questions with our panelists before. So, and this, I think, is the shadow that's hanging over us, is that there have been preventable and unnecessary deaths in our hospital systems across time here in Indianapolis. And so one of the questions that folks are asking, and I'm just going to read the question as we shared with you: if a Black patient feels like that they are being discriminated against in a hospital setting, what should they do? And people really want clear, models of how they respond to that. Are there patient advocates who are specifically trained to support Black patients and their families? What does accountability look like when there are cases of racialized discrimination or problematic care as a result of race? And how are these professionals who engage in racist and poor care remediated or adjudicated? Now, that's a lot of questions. So, I mean, the number one is what we really want you to start off with is, if a Black patient is experiencing something that doesn't feel right, and I mean, and and President Ostley, I often wondered the same question for you: is should a person in the city who feel like they're experiencing racism, what should they do? Is a question that we need to come back to as well. But I want to start with our presidents of the health organizations. What should the Black patient do, or what should their family do in this instance that we know happens too often, and we want to kind of have a response for that? Dennis, would you like to start? Or Brian, let's start with Mr. Mills, and then we'll go to Mr. Murphy, and then we'll end with Dr. Harris.
Once again, I think it's a really good question, and it's also something that we reflect upon as well. One, just to kind of set this tone here, or the response. One, anybody in our organization, whether it's a hospital or any other place, has access to our patient experience department, and they have full authority to take care of whatever it is. Okay, so on one hand, I would say that's what we have, but in reflecting upon, okay, will that person call? We should not hide behind whether that person calls or not. So the two changes that we've talked about as a leadership team and will implement is, one, we got to make sure those advocates, those people in our patient experience, do reflect our population, so that the populations who are looking for somebody to be their advocate is looking at someone or talking with someone who they believe can understand better. And then most importantly, we need to not wait for the call. We need to make sure that we identify, especially and I would say the inpatient setting. I can't tell you that we can do it in all places that we see care every single day, but in inpatient settings, that we need to identify our advocates, that they're identifying patients and they're at least reaching out to the patient to know that they have a voice, as opposed to awaiting that call. And I think that would be a vast improvement, and that's what we're recommending that we do, or that we're planning to do.
Can you just respond before we move on to Mr. Murphy? What does adjudication or remediation look like if a doctor, if a nurse practitioner has been identified by a patient and patient advocate participating in problematic racist behavior? What do we do? What happens? What kind of training? What kind of, what happens?
Well, I'll make this as brief as I can, but one of the things that we are mandating, and we've never mandated this. We have some mandates on here and there and things people have to do, but we've never mandated, but we started and we have mandated bias education. And that's the first in a series of things that we're doing, because, and Joseph, I'm really just trying to be candid with my conversations with other people. I believe we have a lot of things happen in our organization that the people that are in fact delivering racist messages don't believe that they're doing that. And I'm not trying to say it makes them right. I'm saying we have an obligation as an organization to make sure we're going through this process. We're having these crucial conversations. We're educating our entire workforce. And with that, establishing the expectations of what every patient should have within our facility. So that's the process we're going on right now. We've had some things, but they were egregious that we've dealt with, but I can't tell you that everything has been properly dealt with. And that's on us to provide that education and accountability, and people understand how we're going to treat people regardless of color.
And I think, Joseph, maybe it starts with a very simple expectation. We will not tolerate racist behavior in our organization. So you have to set a clear expectation. And maybe like Brian, we have had incidents where that was really straightforward and clear, and the answer and the outcome in terms of remediation was really straightforward and clear. Those people don't belong in your organization. I think the harder part is when these questions are more complex. What was the entirety of this situation? And all of us deal with a set of professionals and others that at least we feel strongly that everybody's entitled to due process, that you've got to actually evaluate the circumstances, understand what went on, and then decide what's the appropriate action to take after that. And again, I'm really candid. We had a very public incident, and we're in the middle of that very set of work. But it's clear to us that we will take the appropriate action, but we've got to ensure that due process plays out during that review. And this one was serious enough and public enough that we wanted not just an internal review of the case, but an external review. And I think that's really important for our organization, for our team, but also for all the patients that they serve, that they can have confidence in coming to our organization to understand how they'll be cared for.
You talked about an external organization. Is there, and this was a question from one of the audience members, I think is just a follow-up, is there an external service or an opportunity if a staff person is knowing that a person who is, that there's a supervisor who is experiencing that behavior, that they could call an external number or provide some kind of critique that would not have immediate repercussions on their own safety and livelihood at the organization? Have you all thought about that, or is there anything in place like that for?
So for our employees, Joseph, we have a confidential hotline that anybody can call. Every employee knows that number. For our patients, every patient who's admitted gets a patient bill of rights. And the very first thing it says is that their care will be adequate, that it will be compassionate, and that it will be equitable. And that if they have concerns, they can call that number. Akin to Brian, we were very conscious. We have about 50% of our patient advocates are people of color. So we did want that to make sure they represented our population. But we also look at lots of other people being patient advocates. I think every nurse I've ever met would say their job is to be a patient advocate. Our social workers, we have financial counselors who are advocating for patients to get health insurance. So we try and make sure that's not one person's sole responsibility, but it's everyone who interacts with patients needs to feel like that's part of their role, is to ensure that patients are heard, that we understand what's important to them, and that we're acting on that. So I don't want to rest the full responsibility in one individual or one category of people. I think that's a collective responsibility that we all advocate for people.
Thank you so much. And Dr. Harris, I want to give you a chance to respond to that. And I'm going to throw one thing at you as well. Are we collecting data on these incidents? So I want you to tell me about what should a patient do at Eskenazi Health if they experience this, but are we collecting the data?
Yeah.
How many instances? So
I do have some data. Probably not as full as you would like, but we've got data that speaks to that specific point. Before that though, I think one of the things that impresses me as I've talked to, again, to all these employees, and we're reaching out because our employees witness hundreds of patient encounters every day. So we're much more likely to really learn what's going on than if we wait for the egregious example that a patient would bring to us. Because patients in general want to try to cut us a break, and but I, in group after group, I hear people describing behavior, and then they'll say, well, but I don't think they didn't mean it. They didn't, I don't think it was racist. I know they didn't mean to hurt me, and I'll call it out. And so, I think that along with our response to the kinds of issues, and they happen everywhere, that result in, a patient wanting to, in our case, reach out to our Office of Patient Experience. I can talk a little bit about how that works in our organization. For every one of those, there's many more of the kinds of stressful events that contribute, that have that slow burn of stress and physiologic stress that is what affects poor health outcomes. We know that that's a big contributor to the increased maternal mortality in Black women, is the constant stress of racism. No matter how hard how fast you run, or how high you jump, or how many degrees you have, how many languages you speak, still getting stalked in Target, or someone wondering if you belong in a particular place because of the color of your skin. Those are things that play out that are harder to get at, that we're working to get at. But so anyway, so we do have the Office of Patient Experience. We located it right in the middle of the hospital, so it'd be easy for people to find the individuals who work in that area, represent the diversity of our patient population, so that they not only people are comfortable talking to them, but they also have some maybe a greater degree of empathy and understanding of the experiences that they're describing. We make sure that it's very visible, very we have multiple ways of making sure people know about it. Again, they round throughout the hospital, so they're actually out on the units. Our nurses, our staff often refer for patients to the Office of Patient Experience, and we go similar to what Dennis and Brian talked about. There are escalations, up depending on how severe the reported behavior is. Some things are immediate, and some progressive discipline, trying to help people understand why their behavior is unacceptable and not part of what we want here at Eskenazi. We also, all this is formalized as part of our Pride values, and we started this about 10 years ago, that our performance appraisals are driven by adherence to these values, and they stand for professionalism, respect, innovation, development, and excellence. And these represent a significant portion of our individuals' review, every year. And we have actually, over the last 2 years, we have terminated 17 individuals for failure to be able to adhere to those Pride standards. When we look at data, the egregious, the things that rise to the level of Office of Patient Experience are relatively few compared to what we think are the bigger issues playing out. That's what we're trying to get as we learn from our employees as they witness what's going on, and then we also talk to patients. And in that regard, in addition to the Office of Patient Experience, we have our Patient and Family Advisory Council, and this group meets monthly, and this is comprised of individuals from our Office of Patient Experience, and several of our senior leaders, but also patients and family members who have either had a really good or a very bad experience with us. And they come, we have topics, there's education, but the main use of the group is to get feedback on any initiatives or changes that we're making. And they give us honest and candid feedback. So I would say, going back to the Pride values, one thing that we have added in response to this work we're doing and what we're learning is that from this year going forward, and we will continue to ramp this up, but as a starting point, each one of our leaders, along with Pride values, we have goals. So each leader has to set goals. Each leader will be required to set a goal that will directly impact diversity, equity, and inclusion. So a goal that's measurable, that we can hold people accountable to. And those goals, along with adherence to the Pride values, constitute 2/3 of a leader's performance appraisal score. So those are significant ways of saying we're serious about this.
No, that's very helpful, and I want to thank you all for those, again, the fulsome and very authentic answers. And I was serious, President Osley, and we're going to move to, I think Mashana is going to kind of move us to closing statements in a minute, where we're running over time, and we appreciate the time that all of you have given. But I was very serious, President Osley, that maybe in your closing statements you can talk about, if a person in our city is experiencing what they understand as racist behavior or practices from a public employee. Where do we report this? Do we call 211? Do we do something else? Is there a mechanism, if you will? If racism is this public health crisis, how do we make it available for folks to name and to document in every aspect and area of our lives? I'm gonna hand it over to Marshawn, and then hopefully you can respond to that. President.
So we are going to go ahead and shift to closing statements given the time that we have left. Actually, we're a little bit over time. And I think what we want to do is move to Dr. Nelson, actually. She's going to help us kind of provide a brief summary of what was outlined in this evening's discussion, and then talk about anything that she thinks is relevant given her expertise in this space. So Dr. Nelson. And then we will move to President Osley and then the CEOs.
Thank you. Yes, this was a wide-ranging discussion. And so I just kind of want to, and I hope this will be the first of many, right? So really what I want to focus on briefly in these final comments is, are places that we might look at in the future that didn't necessarily get covered in the way that we didn't have time, right? So the first kind of, comes out of the conversation we've just been having about racist practice in the hospitals, because I think one of the concerns that we have as Black folks going into a hospital is how is particularly, white providers, how am I going to be looked at? Am I going to be taken seriously? Am I going to be looked at as human, right? And so there have been, some mentions of things like implicit bias training for staff. I would like to think even more comprehensively about continuing education for providers, including things like understanding the history of medical racism, ethics, patient-provider communication, cultural competency, those kinds of things that we do in my program in medical humanities at IUPUI. Another thing that often isn't brought into these discussions that I think is crucially important is the prevalence among healthcare providers of racist understandings of human biology and the idea that Black people's bodies are different inherently in ways that lead to these health disparities. For example, I was talking with someone who is a cardiologist who was surprised to learn that, differences in rates of hypertension are not something different inherently, to Black people's bodies, but rather the result of these social processes. So how do we educate people around those kinds of issues? And then the second point I want to make in closing is more the big picture and the relationship between the hospital systems and the community. And we've heard wonderful things about resource allocation, working with community partners, moving the wealth where it needs to be, support workers, all those kinds of things that were touched on in the conversation. But I think another area to consider is the area of law and policy. These hospital systems have very strong lobbying arms. Are there ways that they can use those arms not only to protect their own interests as hospitals and their own, economic, interests and those kinds of things, but also to throw their weight behind legislation that will impact the health of our Black communities? So things like expanding Medicaid, so doula services are covered under that under Medicaid, or thinking about anti-chokehold legislation. Is that a directly medical thing? No, but that is, those are the kinds of things that have real impacts on our community. And so I hope in further conversations we can delve deeper into those things.
President Osley.
Thank you. I wanted to first address the question that was asked by Dr. Edmonds. I want to be clear that the council has worked in lockstep with Mayor Hogshead and his administration. And I say that specifically because together, through a fantastic grant that was provided to the city, through the council and the administration from the Central Indiana Community Foundation, allowed us to bring in an outside sort of third party to help walk us through this so that we're not creating or recreating the wheel. The organization is called GARE, Government Alliance on Race and Equity. And it is an organization that has been working around the country with municipalities to help them through this particular process. And I mention that in particular because there is a planning team that works with GARE. And one of the principal members of that planning team is the head of HR. So the head of HR is a really vocal member of the GARE planning team. And so if anyone were to hear or to experience some racist, bigoted, biased, behavior, words, they would take it straight to HR. And I would promise you that the HR director would handle it immediately. So as a closing statement, I want to say this, that the disparate outcomes in health and in education and in criminal justice and the environment and employment and the economy experienced by Black and brown residents of Indianapolis are the symptoms and entrenched racism that has become part of the DNA of our systems and our practices over these centuries is the disease. And in order to eradicate that, it is a day at a time, consciously, intentionally, taking actions and being accountable for our own actions on behalf of our constituents and the city as a whole. It's incumbent on any leader in our community for that self-inspection and that system inspection every day. Because if not, we go back to what has been for centuries the norm. And that old norm cannot be our new norm. We have to establish this as part of the new DNA of who we are as a city.
Thank you. I think we're going to time out at around 8:20. So with the CEOs, we'll let you decide who wants to go first, but wanted to give you a heads up. We'll time out at 8:20.
I'm happy to start, Marshawn. I'll keep it short. I think, like President Ostley said, these issues have been around for decades and centuries. And in the past, I would have said, we're going to work to fix this, but it will take some time. I think the last year with COVID has taught us that we can change and we can change rapidly. And we can get a lot of things done if we put our minds to it. And for us, this is one of those issues we need to put our minds to and get things done. And so I think there's a lot about culture, but at the end of the day, I think it is about doing and constantly building in new processes, new procedures, new programs, changing the way our organizations respond to these issues. That will be really important. And I appreciate the opportunity to partner with the Recorder, the NAACP, Urban League, all sorts of groups to help us accelerate the way we address this. So I appreciate the ability to participate tonight.
Thank you.
I would just follow on that, and I like the way both of you have framed this, and especially this, this notion that we can do hard things and we can do it all. And I think this has, as I look at what we have collectively been able to accomplish at the same time as the biggest health, responding to this, the biggest health crisis of our generations before and to come. And I look at how our our people are managing this and embracing it and staying committed. And that's what makes this feel like this is a different moment. You know, I think we look back and we think there have been these moments. There's been a lot, you know, there have been big moments in our history where, you know, where you feel like now, surely, you know, surely this is the point where we start moving forward. But I think there, it feels like there's a collective owning of this, you know, that is required, that's going to be required, not just here, but across our country, that maybe a recognition that's going to be necessary. But it, you know, it seems as though, you know, the momentum is there, and I think we again can see it because of how we are staying focused on this, even with multiple distractions. And I think it's because the pandemic has really brought this to the fore. It's clarified what these issues for so many who may not have been able to appreciate it until they can see what's playing out in the experience here. So I would just say I hope it's clear that we do take this work seriously collectively. We're committed to doing better. We're committed to continuing to listen and to act on what we're learning, and to continue to reach out and invest. And just, you know, once you start thinking about this, you see issues everywhere. I mean, you just, you know, once you've read, you know, we've talked about all the things we've read, you see it everywhere. And it's, and you know, I think that's the kind of thing that strengthens resolve. But I'm looking forward to us coming back together in 6 months. But I think none of us wants to necessarily wait 6 months. That, you know, I would be happy to talk with anyone in the interim and share more and get more ideas, a deeper understanding of your concerns, the ideas to, you know, your ideas about what we're missing, you know, what more we should be doing. I don't want to wait for 6 months for that. And, you know, we're always looking for more folks on our advisory council. So if there's anybody on this call who would be interested, then, you know, let me know. We also are all very focused on getting the word out related to the vaccine. And we have a lot of material that we've put together. We're reaching out to various community organizations to you know, have for town hall meetings. So we would welcome ideas about where we can take this message. Because I'll say right now, we are concerned. You know, we see at the state level that we are vaccinating white individuals at about their rate of, you know, they're within the population, but that's not true for Blacks. It's less than half. And we see that playing out right here. That we've vaccinated over 7,000 individuals, but a lot of them are not from here. They're not the folks we are. So we are feeling the need to really get that word out. So any ideas anybody on this call has, we would love to hear, because we were concerned about it.
Thank you, Dr. Harris. We got about 2 minutes left. Go, Mr. Mills.
Oh, I'll give you some extra time, Marshawn. I've just got a few short points. One point I did not make tonight, I would like to make. I have been at the State House for the last 4 years, representing the Alliance for Healthier in Indiana, to try to address a lot of the things on this call. And we have not been able to get success. We have been asking for a tobacco tax. That's where we are this year. We're trying to make sure that those dollars are used for cessation and prevention, but 100% for public health. We're talking about a $2 tax down there, and $2 doesn't seem like much, but $2 on cigarettes in this state is over $500 million a year. So when you're looking for budget dollars, that's where it sits. And I still believe that that's something we can all rally around and find benefit for. The second thing I would throw out again, and I know I've said this a couple of times, but I'm all ears and I'm all time on trying to figure out what actions can we take, or I'll just say, can I take, to help establish trust? What can we do? What can we do with your help to change how our organizations are viewed, and to make sure that we can improve this by working together? And I still think this whole unity idea, you know, I always tell people community, that's our name, or the last 5 letters are the most important, is unity. And that's what I believe we should be all about. So I appreciate being invited here tonight. I've learned so much, and I appreciate your passion.
Thank you so much. Whatever happens to us and without us is done to us. We thank the CEOs for being here, for being transparent. They shared information that was informative in a positive direction, particularly the way they've been able to serve Black patients inside the hospital. But they've also been transparent about issues such as leadership within their internal organizations and the efforts to move toward that. And so we appreciate that candor. Now that the conversation has been opened, what are the next steps? How do hospitals plan to communicate their progress in these areas and better engage the community going forward? We'd love to have a 6-month update. We will be reaching out as a community. We promise to stay curious, to stay interested in the work that you're doing. We appreciate the time that we had with you. I don't remember the last time the Black community has had a conversation with 3 CEOs from our local hospitals, and we should do that more often. And so I thank everyone for their time. Good evening.
Thank you.